Good afternoon, everyone. Wow. First of all, I want to say thank you for turning out today. Thank you for being here to learn more about Massey Comprehensive Cancer Center. But I'd like to start I would like to recognize our cousin, Carol Fleet, in the room. Thank you, Carol, for being here. I think Jimmy Fahrenholt's here somewhere, a one-time brother-in-law. Thank you for being here. And so many friends. It's been so heartwarming to reconnect with friends here. It means so much. I am very grateful for Mrs. Phyllis Katz. Phyllis, are you here? Who treated me to a lovely lunch. That was wonderful downstairs. And it's just Deedle. It was nice to have Deedle join us and also to see so many friends there. So thank you for such a warm welcome here at Cedarfield. The one time I came here before, I loved being with you. I loved sharing the Cancer Center and what we do. So thank you very, very much. Today I'm going to share a little bit about me, and then you're going to have a program from Dr. Sutton, an expert at Massey, and she's going to share with you some very important cancer information. So I am a member of a Massey family. I married Carol Fleet's cousin. She calls him Little Billy. And it has been my honor and pleasure coming from the mountains of eastern Kentucky up a holler with school teacher parents back in the 1950 on, and to come to be a Richmonder 54 years ago and learn this community and how important it is and how generous this community is. It's really been very eye-opening and been a wonderful opportunity to be a part of this. So I spent my marriage raising 3 sons, but also doing volunteer work in the community, from being the school mom to working at Maymont. We are all familiar with Maymont and what it means. To the Virginia Museum. We all know what that means to us. And any of you that have not seen the Giants exhibit that ends this week, it is phenomenal. I encourage you to try to go if there's an opportunity. And just being part of the community. So in mid-90s, I decided to do something that my family had been very involved in from its founding, and that was in 1974. The Cancer Center was found at Virginia Commonwealth University. And it started out as just being expertise in cancer surgery. It was just so well needed here. We had a cancer surgeon come. Our first director was, Jasmine, our first director, Walter Lawrence. How many knew Dr. Walter Lawrence? Wasn't he fantastic? The growth he did, the way he knew how to develop a cancer center, to also treat patients, but to do research and to educate our community. And he, for all his years there, was so engaged, so involved, so he really is the root of the tree that started Massey Cancer Center, and then there's been all these branches. My family was honored in 1983 to carry the name of Massey Cancer Center because some of our relatives, including Carol's mom, had been treated there. So cancer was very important to our family. It has been such a pleasure for me to be a cheerleader, friend raiser in the community, and a fundraiser for the Cancer Center, because realizing the importance of having this expertise in our community that an academic cancer center offers, watching it grow and develop through the years, watching some of the researchers that were hired with their fantastic research coming to the point that 4 years ago now, I believe it is, we were actually designated as a comprehensive cancer center, designated by the National Cancer Institute, which is a part of the Federal Health Initiative, NIH, National Institute of Health. So in order to get that, you have to have proven excellence in the treatment, the research, and the control and prevention of cancer. And Massey extends that one bit farther to having the reach out into our catchment area, which is the area that we serve patients. If you take the state of Virginia and divide it down the middle, Massey serves the eastern, central, southern part. UVA, the other comprehensive cancer center in our state, serves the western and southern part of the state. So we've sort of divided the state of Virginia so we all can do our treatments, our research, and our control and prevention programs that serves the whole state of Virginia, which is exactly the way it should be because we all get support from the state of Virginia in some small way, but it very much helps us advance our research. And we know that research is the key to living a better quality of life with cancer, and we know that research advances cancer. So we really haven't often a saying, and I think Dr. Sutton may talk more about clinical trials and what they mean, but clinical trials are tomorrow's treatment today, literally. A clinical trial means options. A clinical trial can happen upon the day of diagnosis. It's not something for just the end of treatment. I think the school of thought for so many years is after we finish standard treatment for cancer is, well, maybe there's a clinical trial for you. But we really stress today, clinical trials can start at the beginning of treatment. The other little thing here is survivorship. We generally think of survivorship in the past as at the end of our active treatment. Well, really, survivorship starts the day of diagnosis. So that's when we should be part of a survivorship program. How do we survive cancer and have better quality of life? How do we get our needs met? So Massey currently has a survivorship program with a chair of the survivorship, and it's a fantastic program that helps a patient for all their treatment that they need in addition to the cancer. So it's a very, very wonderful way to help treat the whole person. My involvement today, after being a cheerleader and friend raiser and fundraiser, started out being awareness of a cancer center in our community, to today mostly doing patient advocacy. That's being in the clinic with our patients, finding ways that we can enhance the patient treatment journey. How do we do that? We've done things like we have built a healing room within the adult outpatient clinic. It's a beautiful room with a 16-foot screen, and it's curved, and you can go in this room and listen to beautiful music, or you can use a little pad and you can transport yourself to the beach, or the aspen trees out west, or snowfall, or a river in Texas. It's just sort of how to decompress, how to have some mindfulness. I cannot tell you how many patients and family members I've taken there, and they say, this is just what I need. We do other programs like the Ramble. It's a walking twice a month. We walk at Stony Point Fashion Mall, and then we walk downtown at the park. So there's programs like that. We do constant education. We help do transportation funds for patients that have to come far away. Oh, you want to hear one of the latest exciting research we're doing? This is so far-reaching and so wonderful. Our chair of hematology oncology, Dr. Martins, his lifelong project has been how to take chemotherapy to the communities, instead of the community members having to drive so far to come to a flagship place to get their treatment. So we call it Chemo on Wheels. He is at the point now, he has gotten all the approvals, the FDA approvals, the VCU health approvals. He has now ordered the, I don't know if I want to call it a truck, a trailer, a thing that will actually have 4 chemotherapy chairs. It will have ability to do telehealth. It will have a blood draw lab, and it will have all the staff members therein associated. And he is working with the Virginia Department of Health to be able to facilitate it in their locations, to go throughout, especially Southern Virginia, which is really, really exciting, and that's thinking out of the box of how do we have access for everyone to get treatment, which is one of the things I think we're all most proud of at Massey, is our doors are open to everyone, regardless of ability to pay. That's called a safety net for the state of Virginia. Virginia has two safety nets, Nova, Northern Virginia, and us. And I think I may have just read Roanoke got that designation. But that is our mission. It's always been Massey's mission since 1974 that we're there to treat everyone that needs it. So it's cutting edge treatment. It's the latest information. A comprehensive cancer center can't treat all cancers. There's too many. But we know where the expertise is around the country, and we collaborate and we work with scientists and physicians and faculty members at other cancer centers across the nation. So it's very exciting times to have that comprehensive designation. In 18 months, we will be reapplying for it again. You have to renew every 3 to 5 years. It's a 1,500-page application. So our scientists are already at work. It's all about all your programs you're doing. How do you educate your communities in your state? How do you treat patients? What's the latest treatment? How do you prevent and control cancer? Those are the real things you have to have lots and lots of information and have it all written up and make this application. It's peer-reviewed by other cancer center directors and scientists, and they decide if you get your renewal. There's only 2 you can be renewed as a clinical cancer center or a comprehensive cancer center. Comprehensive is the highest designation you can have, and this designation automatically puts us in the top 4% of cancer centers in this country. So right now we're working really hard to provide all the resources that our director and his team need to do the research they need. So pretty exciting days. Any of you that keep up with the state legislature, one exciting thing coming up is the budget that will be submitted. I believe the end of this week. We're hoping the state will purchase Altria building downtown for VCU Health, because that is super important to Massey, because we need wet lab space. We do not have enough. We cannot recruit these fantastic scientists from around the country if we do not have lab space for them. So we've all gone to the legislature to say, please support this, and so far it's looking good. And the recruitment I mentioned, we're so successful in recruiting because our director, Dr. Robert Wynn, he's a superstar. No other word describes him. He has brought incredible acclaim to Virginia Commonwealth University and its health system and its cancer program. He is a visionary of what a cancer center should do, how it provides access for everyone, no matter where you are, who you are, or what your zip code is, because there has been in history of disparities according to your zip code. So he has ways and knows how to bring that all together, and he is a national speaker. He's been head of the AACI. He is head of the chair of the American Cancer Society, just extremely involved and extremely passionate. And he speaks the passion. He came to us from Chicago right at the beginning of COVID. So we hope to keep getting him out in the community more. So I think that's about all I have as updates and about me. And just again, I want to say thank you for welcoming me with open arms all the way today. Are there any Massey Club members in here? Anybody already support Massey in here? Thank you thank you so much. The community, the investment by the community, people just like you sitting in every one of these chairs. You're why we're Comprehensive Cancer Designated Center today. Your investment has allowed the research, the treatment, and the prevention programs to happen and get us here. So I just want to really say thank you for that. There we have a society called the Massey Club, It is our members that are $1,000 and up each year, and we do very special programs for them. We may do a panel, we bring our experts for you to meet, our researchers, and we can do one-on-one meetings for you with any of those. So keep that in mind. Just a little plug. I know this is not a fundraising day, but always have to put that in there of how important your funds are to get us where we are and to say thank you to those that do. So this time I'm going to introduce you to Dr. Arnethia Sutton. Excuse me for reading. I don't usually have to do this, but she has some accolades behind her name. She's an assistant professor in the Department of Kinesiology and Health Sciences. She's an affiliate faculty member in the Department of Social and Behavioral Sciences at VCU School of Public Health, and an assistant director of community outreach and engagement at VCU Massey Comprehensive Cancer Center. She received her PhD from VCU 2017 and did a postdoc fellowship in cancer prevention and control at VCU in 2022. She's a principal investigator. It's Cancer Advocacy and Research in Survivorship, or CARES lab. She's funded by the NIH, remember that's a National Institute of Health, and has an innovation pilot project or program that's funded by Massey. She's focused on developing the community and clinic-based interventions to address disparities in cardiovascular disease among the underserved population. Dr. Sutton currently serves on various professional and community boards and committees, which include the editorial board of the JACC. You'll have to tell us what that means. Cardio-oncology, and the board of directors for Here for the Girls, a breast cancer survivorship program that was founded in Williamsburg. Okay, if I leave anything out, I will be hanging around a little afterwards. You'll be able to ask questions, and we look forward to also with you hearing our next program. Thank you.
Well, good afternoon, everyone. I just recently, so I'm still in the classroom, I'm a professor, and I had a class of 60, 19, and 20-year-olds about 3 hours ago, and I told them I was coming here, and I said, I'm so nervous. And they were like, we're the ones you need to be nervous about. And they said, well, who do you think is going to be the better listeners? And there's no doubt in my mind that it will be you all. But we will see. So I'm really thrilled to be here with you all today. As you can see from my slide, we were asked to talk specifically about cancer screening and decision making, okay? And particularly when it comes to individuals that, like Mary Helen Hackney said, I consider 70 young now. So if we're 70 and above, that's what we're really gonna talk about, because that's where the guidelines and things get a little bit murky. Before I start, though, I just want to give you an outline of what's been going on with regard to cancer. So Becky did an excellent job of talking about the Cancer Center. When it comes to cancer, we're seeing the rates of cancer go up, unfortunately. But the good news is that we're seeing the cancer death rates go down. And that has been consistent at least over the last 10 to 15 years. So things like clinical trials and all of our new treatments, different screening modalities, which I'll talk about today, have helped to contribute to the fact of seeing the decreasing mortality rate. The question everyone always asks, though, is why are cancer rates going up? And this is part of the reason why it's important that we recruit some of the best and the brightest at Massey, because we are definitely at the forefront of trying to answer that question. Some of the hypotheses I hear when I'm out in community settings, the number one is the environment. And especially amongst our younger individuals, they really believe that there's something in the water, in the air, maybe something called microplastics that's contributing to why we see the increased rate of cancer. But we also know that if you screen more, then you will find more, okay? And we see a drastic change in the technologies that we have now when it comes to screening, so we are able to find more. And the unfortunate side is where we really are seeing our increase in cancer rates are our younger individuals. These are our folks in their 40s. And so we're gonna talk a little bit about how we're detecting that and why we're seeing that. I want to take an opportunity to talk about community outreach and engagement which Becky did describe. That's the office that I'm a part of. And what I want you to know is that we combine our strength of science in our cancer center programs and the wisdom of community and strategic partners to strengthen our ability to reduce the burden of cancer in our catchment area. That means that not only am I here today to tell you all what I know, but I'm hoping we can have a dialogue. We can learn from the questions that you ask and take those back to the Cancer Center and say, these are what some of our partners feel are really important and some of the questions we need to address. And so we say all the time, Dr. Nguyen reminds us, one team, one fight. We are all a team, and we're all here to fight against cancer. Becky also spoke about the catchment, so I'm glad I have a map here because you can see our catchment. So we are funded by the state, by the federal government, and of course through generous donors, and this is the area that we are responsible to serve. I show this because you see the star is Richmond, really very slightly west from the star is where Cedarfield is. You all are a part of our catchment. You all are our community. As a cancer center and a comprehensive cancer center, it is our responsibility to serve your needs with regard to cancer. You can see also at the very bottom, we serve 66 localities, which include some independent cities and some counties. We have a fair share of rural counties that we do serve, and then 54 of our 66 counties are considered medically underserved. Some of those in some of our rural areas where they might not have access to a hospital or to primary care. And so as the Comprehensive Cancer Center, we do what we can to get out in those communities to provide adequate cancer care. Now, since we're going to talk about screening, I want to give you an idea of what the numbers look like in Virginia in comparison to the United States, and I can even show you what our numbers look like within our catchment alone. So this first graph here shows you cancer incidence, and what you can clearly see, in comparison to the US and Virginia, the Massey catchment, our incidence is higher. This again is why we are so committed to getting the best, the brightest scientists and clinicians and researchers so we can answer these questions and understand why we see this. In addition to that, we have in our catchment the highest mortality. You go back to our previous slide, you saw we serve underserved individuals. We serve some areas, some rural areas where they don't necessarily have adequate health care. So we are challenged within Massey to address some of these needs. This is broken down by cancer type. So you can see when we look by cancers, the bottom or the reddish color is Massey and the gray color is the US. You can see across the different cancer types that we're slightly higher than the US average with regard to mortality. These data are really important to show because if we show Virginia as a whole, generally speaking, folks at the federal level, they're like, oh, Virginia's doing fine. Maybe our resources shouldn't go there. But this is why Massey says, okay, let's take a more granular look at what it looks like for the folks that we serve so that we can tell a coherent story about why we need the funding and why we need the resources at Massey. Now, since we are going to talk about screening, I decided to show a couple of graphs of where we are with regard to risk behaviors and screening in Massey. So this first one is the HPV vaccination, and you can see this is specific to 13 to 17. Right now, we do not have the data for Massey, but you can see the Virginia versus the US, and we're doing slightly better than the US with regard to vaccination. Additionally, with colorectal screening, which we will talk about today, our Massey catchment is doing better than the US and Virginia. Now, mammography, we have a little work to do. So you can see with mammography, we're doing slightly poorer with regard to Virginia and the United States. When we think about risk factors, one of the primary risk factors that we really are focused on now is obesity. Studies are continuing to show that there are many cancers that are implicated because of obesity. So obesity is certainly a risk factor for cancers, and as you can see in our catchment area, we're slightly higher than the state and in the US. Smoking, which is something that we've been dealing with for a while in the Richmond and greater Central Virginia area. We're doing worse off when it comes to the Virginia, but we're about where the US is, and it's still an area that we're focused on. And then life expectancy, there isn't much difference there with regard to our catchment, Virginia and the US. Now here, again, is our catchment map, and some of those localities on the right you might recognize. The one I believe that's closest to here is Petersburg. So we found through looking through our data that in our catchment, there are some localities that fall within the top 50 of the highest cancer mortalities in the US. So there is a lot of work for us to do, which is why I'm really happy that you all requested for us to come today, because we appreciate when communities are saying, yes, we want to know more about what's going on, what we can do to help ourselves, and what we can do to help our neighbors. Now, I want to take a moment to show you this because just like me, there are other researchers and scientists who go out in different settings to talk about cancer, but you know, everyone doesn't have the opportunity to sit in a beautiful place like this and learn. We actually have to get the information out. And so a few years ago, we were fortunate enough to get some funding to have our Massey on the Move vans. These vans go throughout our entire catchment, sharing information about cancer, giving opportunities for folks to be on clinical trials, navigating folks to screening. And when I say navigating the screening, if we come across someone who says, I haven't had a mammogram and I'm 55 years old, okay, we certainly need to get you a mammography. Where do you live? Oh, I live in Dinwiddie County and I can't get to Massey. That's fine. We will find you the closest place to where you are to make sure you get a mammogram. Because it's not necessarily about folks getting to Massey, it's about making sure people get timely care. How our vans, this is a snapshot of what our vans look like. They were designed by artists, local artists here in Virginia. This is one of the ideas when Dr. Wynn came. He's like, we got to get out and on the move and in our catchment. And so we were able to get these beautiful vans to get out here and get access to trials and screening and education. Now we're going to pivot. We're going to talk about the screenable cancers, okay? And what I'm going to present to you is the newest information about where we are with regard to cancer screening and guidelines, all right? And I decided to take a different approach to this. So at the very beginning, this is my disclaimer. At the very beginning, you saw my name, and after my name, it said, comma, PhD. That is important because I'm not an MD. Okay? And so what I did was a couple of days ago, I emailed some of my fantastic MD colleagues at Massey, and I told them I was coming here, and I said the conversation is going to be around screening. I need to know, what do you tell your patients who are considered in our older than screening sometimes age, what do you tell them about screening? And many of my colleagues wrote back. Some wrote back way more than others, and you'll see in just a second. But I pulled their quotes so you can see what are the physicians or the clinicians saying about these topics. So first we have breast cancer screening. Now, generally speaking, the American Cancer Society will offer some guidelines and recommendations, but we also get guidelines from the United States Preventive Services Task Force, also known as USPSTF. Now, this one here you can see, women should have the opportunity to screen, or the option to screen, starting at age 40 to 44, which is what we really promote, okay? But the guidelines state absolutely at 45 years of age, women should be getting a mammogram every year. That is what the American Cancer Society recommends. Then we see here 55, and this is where it gets interesting because they leave it open. 55 and older, we see women can switch to a mammogram every other year, or they can choose to continue yearly, okay? Screening should continue as long as a woman is in good health and is expected to live at least 10 years. Now, if we go to the USPSTF guidelines, which look a little different, what they tend to do is they grade their guidelines. So they say this is graded off of what we see clinically. After we've done a lot of data, looked at a lot of data and a lot of analysis, they have given the recommendations for mammography a grade B, which is really good. And they say here, we see an NCAP. Women ages 40 to 74, they recommend biennial screening mammography for women in these ages, and that's a stage B, okay, a grade B. You see the others there where they have 75 years or older, that the current evidence is insufficient to assess the balance of benefits and harms of screening mammography in women 75 years or older. This is why I went to my clinician colleagues, because they're certainly having these discussions about what to do there. But you can see that's inconclusive. There's not enough evidence there for them to grade it as an A or a B, okay? And we'll get back to mammography in a moment. I just want to make sure to cover all the screenables, okay? Now we have screening for colorectal cancer. This is a little different because they focus on who's at risk. So this is focused on individuals at average risk, And the American Cancer Society recommends that people at average risk of colorectal start screening at 45. This guideline changed about 6 to 7 years ago. Prior to that, it was 50, and they changed it to 45 because we're starting to see colorectal cancer in younger individuals. I remember the day that it changed to 45. I was at a conference in Salt Lake City, and everyone cheered and was so excited, and then someone says, now it needs to be 40. Because we do see it younger, but with the evidence, we have to continue to gather the evidence for the recommendations or the guidelines to shift, okay? People who are in good health and with a life expectancy of more than 10 years should continue regular colorectal cancer screening through age 75. You can see from this guideline and the previous one, there's this trend here. We see this thing of 10 years. So the question is like, well, how do I know how much longer I have? What kind of conversations do I need to have with my physician about that? And we'll talk about that. 76 through 85, the decision to be screened should be based on a person's preferences, life expectancy, overall health, and prior screening history. I'm going to highlight the term preferences, okay? What I've seen from my clinician colleagues is that they really are focused on what you, as the patient, are most comfortable with and what do you want to do. Then we have people over 85. They say should no longer get colorectal cancer screening, okay? And this goes back to the question is like why? It goes back to maybe going back to the 10-year life expectancy. It goes to the risk versus the harms of getting colorectal cancer screening and what may be found after that. But again, we're gonna focus on our decision-making processes. Just like I showed you with mammography, you see this here. So these are the grades that the USPSTF give the guidelines. So 50 to 75, they give it an A. Now you see down there, so you see practical considerations. One of the things that's really cool about colorectal cancer is there's so many different ways to screen for it, okay? Now what folks will consider the gold standard is colonoscopy. Everyone's not comfortable with colonoscopy, and we recognize that as we get out into different communities. So there's ways that people can do like stool-based fit testing that look for like occult blood. There's ways that they can look for antibodies with regard to like a same type of approach. There is now a blood-based test for colorectal cancer screening that has just launched within the last year or so, which Massey now we're starting to get more into because again, it helps with accessibility. And some folks are not the most comfortable getting colonoscopy. So as we work towards getting folks more comfortable with that, there are different types of screening modalities for colorectal cancer. You can see the grade B, the USPSTF recommends screening for colorectal cancer in ages 45 to 49 years. And so I told you this recently changed where they lowered it to 45, but they have not moved it to a class A yet, or a grade A. However, insurance companies, people are covering at age 45. That is when clinicians are recommending that folks start to get their screening. And at the very bottom, we see a grade C. So they recommend that clinicians selectively offer screening for colorectal cancer in adults aged 76 through 84. Evidence indicates that the net benefit of screening all persons in this age group is small, okay? Now, we can go on and on about what we mean, like net benefit, and who's to say what a benefit is to someone? You're the person that can say what the benefit is. And that's why I was really happy that my clinician colleagues were all like, I like to have conversations with my patients about it and not make the decision for them. Now, the one that generally people don't talk enough about is lung cancer screening. Okay, so lung cancer screening you can see is a grade B. The screening for lung cancer, it has a different, like I would say, guidelines than most because it's based on a few criteria. So they recommend annual screening for lung cancer with low-dose CT in adults aged 50 to 80 years old who have a 20-pack year smoking history. And that means that you have smoked a pack of cigarettes a day for 20 years, okay? Currently smoke or have quit within the past 15 years, all right? So those are the criteria. So if you were a smoker, but let's say you just quit in the last 14 years and you're 60 years old and you were a pack-a-day smoker, you are still eligible to get lung cancer screening by low-dose CT, okay? A little more clear with these guidelines than some of the others. Now, I do have this one here, cervical cancer, all right? So cervical cancer is one of those ones now that we have the HPV vaccine, so it's really one of those ones that, no one should be getting anymore. And we've been seeing some emerging data from other countries that have shown how remarkably drastically their rates of cervical cancer have decreased. You can see here that they recommend cervical cancer every 3 years with cervical cytology alone in women aged 21 to 29. For women aged 30 to 65, they recommend screening every 3 years with cervical cytology alone. Now, I asked one of my clinician colleagues, okay, what if it's someone over 65? So she was one of the individuals in the group that I emailed. And, I love my clinician colleagues, but they're an interesting bunch. And so as I was pulling into the parking lot, she called me. And she said, when do you need to know that information? And I was like, right now. And so she says, okay, let me tell you really quick. Really, we follow the guidelines with cervical cancer. 65 is pretty much it. However, if someone is considered high risk, maybe they've had some abnormals in the past, or maybe they have never been screened, that's when we would consider something else, okay? So if that may be you or someone you know, then it may be a conversation to have with the provider. You can see the other criteria there or recommendations there have a grade D. No one follows grade D recommendations. We tend to stick with B and A. All right? And now I saved this one for last, prostate cancer, because prostate cancer has been one of those ones over the last at least 20 to 30 years that we bounce back and forth. At first, the PSA is good, and then it's not good. And now it's good again. So I was like, I'm gonna save this one to last because things are a little interesting. This is the American Cancer Society recommendations for prostate cancer screening. Age 50 for men who are average risk of prostate cancer and expected to live at least 10 more years. Age 45 for men at high risk of developing prostate cancer. This includes African American men and men who have a first-degree relative, you can see their father or brother, diagnosed with prostate cancer at an early age, which is younger than 65. And then age 40 for men at even higher risk. Now, if we go to the USPSTF guidelines, you can see the highest grade they have is a C. Okay, and so without reading that there, part of the reason why we have such a hard time with PSA is because it has a very interesting false positive and false negative rate. So what that means, false positive. The false positive rate for a PSA is about 10%. That means that they're saying, oh, it's positive, but it's really not. It's false positive, so it's really not positive. So think about if a male has a positive, they think it's a positive PSA, the subsequent testing, the stress, all that goes into it to only find out, oops, that wasn't really right, okay? In addition to that, it has over a 20% false negative rate. Think about what that means. So that means it's saying it's negative, but it's really not. That person actually does have cancer. And this is where we've had issues with the prostate-specific antigen for years. Okay, right now, we got this C, we do focus on age, so high-risk men around 40 to 45 and definitely 55, but we give this is definitely where we see shared decision-making happening the most out of all of our screening with prostate, okay? So, like I told you, those are the guidelines. Anybody can find those, but that does not tell you still, like, what will you do? So what did our doctors say, all right? So here's one of our breast cancer docs that I emailed, and she said, I don't have many patients undergoing screening mammogram in their 80s unless they have a recent history of breast cancer. For those who are in their 70s, if their health is good enough that they can undergo breast cancer therapy reasonably well and their life expectancy is 10 years or so, then it can be pursued if the patient is interested. So again, that tells me that there are discussions that are being had with regard to the patient and the provider. Now, one of my OBGYN friends had a little bit more to say, but I appreciated what she said. She usually discusses the screening after the age of 75 is individualized and it isn't one size fits all. I discuss its importance to look at the whole person, not focus on their birthday in the chart. We would consider their overall health and comorbidities or other chronic conditions. If they have multiple chronic conditions or limited life expectancy, the potential benefits of screening may be smaller and the burdens may be greater. I also discuss how past cancer diagnosis, family history, prior biopsies, et cetera, can shape our conversation and decision to screen or not screen. It's important to also look at a patient's experience with screening. As for some, it can cause discomfort, anxiety, or logistical challenges that they may have had with screening. Lastly, I would center the conversation regarding the patient's values, as some people feel strongly about continuous screening because it may give them peace of mind, while others prefer to avoid tests that may lead to additional procedures that they don't want. And I appreciate what she says because what it shows me is the importance of advocating for yourself. If you feel very strongly about screening, regardless of your age, then you need to tell your provider, I really feel strongly about screening, for whatever the reason may be, and your provider should be receptive of that. And I tell a lot of folks that I talk to, they're like, well, what if my provider isn't receptive? And what if they won't listen to me? Well, what I say is I treat my providers like my hairstylist. If you mess me up one time, I might come back, but you're not gonna mess me up again. So if you're not hearing what you want to hear from your provider, then you should definitely seek another opinion, because I'm seeing from providers that they are open to having a discussion about screening. Now, one of my favorite breast cancer docs, I was like, you could just give me a quote or two, and she was like, no, here's an outline. So let me just give you a synopsis of the outline, okay? So this, and she says, screening for older women. 70 is what they usually consider as older. To me, that looks younger all the time. There is no mandatory stopping age. 75 was proposed, but it was not mandated, okay? It becomes a discussion, again, of risk versus benefits. So she talks about other chronic conditions. She talks about, if we find something, are you healthy enough for surgery? What do you feel about that? Are you healthy enough for other types of treatments? Increasingly, therapies are being dialed back in older patients with cancer, so maybe not doing radiation or such. Women who've previously had breast cancer are often reluctant to stop. So if you've previously had breast cancer, you might not want to stop being screened. You're like, I want to continue being screened because I've had it before. And so this physician is open to those conversations. Now, with regard to colorectal cancer, this physician says, I tell my patients that the guidelines are exactly as the name states, and they're not absolute. I recommend continuing doing screening and not stopping at a particular age if I feel they can safely tolerate the procedure and can navigate the treatments that may follow an abnormal test. So again, this is showing us that even though they have those ages at the end, physicians are open to the conversations about folks continuing their screening, okay? Prior to me, again, I had 2 phone calls on the way here. One was my OBGYN friend, and the other was a friend who is a urologist, because I asked him about prostate. And he said, you know, with regard to PSAs, I do try to stick to that 60s to 70s. Once we get above that, then we really are talking about life expectancy and risk versus benefits. So if I had to say what the theme was in all of this, the theme is that no matter what we see with regard to the guidelines, conversations are being had and people are getting their screening after the ages that are in the guidelines. So I would recommend that you do have the conversation with your provider if that's something that you're interested in. Now, as I close out, because I want to give time for question and answer, I do want to give you all this information. Now, today, it just so happens it was today. Massey just recently started a monthly observance of cancer. And what we do is we bring an expert onto Zoom, and folks all over watch. I think this is our 3rd one, and I heard today we might have had over 170 folks on the Zoom. We have an expert. You can ask the experts questions. They tell you about the cutting edge, what's going on with the cancer, and we have it every month. And we'll make sure if you all don't have that information that we'll make it available to you. We also have materials that have been really helpful. We have new materials that are focused on individual cancers, and what makes these individual materials so great is that they have a code on it that you can scan, or a website you can go to determine if you are eligible for screening, and or to say, hey, I want screening, help me to get to screening. And someone will give you a phone call and help you to get to the type of screening that you want. So I'm going to end that there. I'm going to thank you all for listening. I am open to questions. I do survivorship work, so if there are questions about cancer survivorship, I can certainly answer them, in addition to questions about screening. Thank you very much. There's one question. Do we have a mic? All right, let's do it.
You want me to take the mic?
I can do it. I need the steps.
Okay.
I feel like I've been sitting. All right, let's
Is
do it.
everybody awake?
Testing.
Let's all, while she walks to the questionnaire, let's all take a really nice deep
Oh,
breath.
yes, ma'am.
In for 2 seconds.
Oh, we're breathing.
Out slowly. Just relax. Don't go to sleep on us there.
I just want to say thank you to the Massey Cancer Center. I had my first treatment experience there in 1983 for a very rare ovarian cancer that at that time had a 10% survival rate. My specialist said, I've called around the country, and anybody who's treated this has treated a maximum of 8 or 10 cases. And they've developed something at MD Anderson in Texas that we're going to try on you. So thank you. I've also outlasted my breast surgeon for the breast cancer that was successfully treated there with radiation, the skin cancer that had the skin graft on my nose, and lastly, the bladder cancer 5 years ago. So I'm now part of your cancer survivor clinic.
Thank you for sharing. I do want to say one of our breast oncologists mentioned, although we did not talk about skin cancer, that is one that is very important to consider. We don't have, like, there's not normal, I keep going, let me go up here so it doesn't go out. There are not like guidelines around skin cancer. Okay, so when you go and you look up what the guidelines are, or how often you should go to the provider and talk to them about them, there are no guidelines. What we are recommending, though, is one, that we all pay attention to our skin, particularly as we get older, and anything that looks abnormal that you absolutely report it. If you have someone, what one of our physicians told me, if you have someone that even helps dress you or whatever the case may be, that you ask, you pay attention to my skin, and if you notice something, please let me know. Because unfortunately, that's just not a part in the US health, unfortunately, of like one of the guidelines, like we have some of the other screenable cancers. So I'm glad you brought that up. Thank you very much. Yes, so same with mouth. So knowing what they call like your mucosa area, looking inside of your mouth, and generally, thank goodness, if we go to the dentist usually will check for you and they'll look, but there's nothing wrong with looking and making sure you don't see anything that may look discolored or anything that may be growing in there. So thank you, Becky, that's a good point. All right.
What would be the symptoms that we should consider before lung cancer screening?
That's a great question. The symptoms that you can consider. Here's the thing about lung cancer screening, or lung cancer. You saw the guidelines. A majority of lung cancers, and we're seeing a growing number of them, unfortunately are non-smokers. So this is an area that's very difficult right now because you saw the guidelines are for smokers. Generally speaking, what they're asking you to look for, if you have, and I heard Dr. Nguyen mention this recently, if you have a nasty cough that will not go away, that is generally an indication that you need to get something checked out, okay? Which makes it hard this time of year because many of us have coughs, but if it's just one of those ones that even if you get, like you take some kind of suppressant and it's not going away, that's generally the first sign that there may be something going on. Outside of that, it may be some chest pain, but again, this is very similar to other instances. So it's kind of one of those ones that's really difficult, but the cough is one of the symptoms that we tend to look for. I thought I saw, oh yeah, let's go. Excuse me.
Could you tell us what the Massey Center is doing in terms of cancer genetics and outreach to families where there may be genetic propensity for cancer?
Yes, excellent question about genetics. We work very closely with our human genetics department. And one of the great parts about the human genetics department and what Becky mentioned, the survivorship clinic, they work very closely. Because what they're trying to do now is, should I stay here? Okay. We can identify folks that maybe were diagnosed, because what we're looking for generally with hereditary cancers is someone that may have been diagnosed earlier. And we're doing extensive family histories to the point that people can do with regard to our patients. Then the survivorship clinic and the human genetics clinic are working together to get folks tested and to get subsequent family testing if possible. So this is an area that I have seen grow. I think I started my postdoc in 2017. The survivorship clinic came around 2021, and we have made tremendous strides to try to get folks screened with regard to hereditary cancers and their families if we find necessary. The good thing about the genetics now with hereditary cancers is that we're seeing, with regard to coverage for insurance, a lot of these tests are now being covered because they have been we've been testing them so extensively and because of clinical trials. When years ago we were still seeing there were lots of cost barriers with regard to that. Probably in the early 2000s, we're not seeing that anymore. So we have made tremendous stride with regard to getting people tested.
I might add another thing to that that's really important is keeping a family history. If you all can keep your family health history for your family, that is so important
By trade, I'm a family practitioner, and the question was asked, when do I know that I should be screened? I think you know your body better than anybody else does, and if something is different and something doesn't go away, that's where you start, and that's where the workup starts. And there's nothing wrong with going, there's nothing wrong with a workup and have somebody say everything is okay, or we're gonna follow this, we see this, we wanna check it in 6 weeks. So most of it is doing due diligence for yourself.
Thank you very much. Can't emphasize that enough.
I was going to echo what Dr. Johnson just said. I'm a survivor of metastatic stage 4 cancer, and Massey saved my life. But what the doctors told me then is good advice. They said, we didn't find it, you told us where to look. So continue telling us what your symptoms are so we can look and look further. And I think it's wonderful advice that you shared, and I'm here today. No one expected me to be here. Thank you.
Thank you so much for sharing. We can't press that point enough. No one knows your body like you do. We can't say that enough. Thank you so much.
I hear that there is a blood test you can take now to find out if you have cancer somewhere in your body.
So there is. It is a multi-cancer early detection test, okay? And there are large trials going on right now for that. So it's not standard of practice yet, but there are clinical trials. And fortunately, Massey is one of the sites for that trial. We actually were the first site in the whole country to kick the trial off. So it is a trial to test, it's a blood test, and it's to determine if you have certain markers for certain types of cancers. Okay? And we're hoping that if this trial goes well, that means that we talked about false positives and negatives, that the test is sensitive enough where we don't see those, then that could end up becoming standard of care. So this goes back to what Becky was talking about trials. So we do have that trial available, and if that is something, I don't know the criteria for eligibility, but if that's something you're potentially interested in, we can make sure that information is made available here because Massey is a site for that trial.
Yeah, I did it. I think there's one that's for over 50s that you can do. There's one for survivors and one for non-survivors. And I cannot tell you the peace of mind it has given me because I very recently got my report back that they did not should see any markers because once you're a survivor, how many survivors do we have in the room, by the way? I forgot to ask earlier.
That's incredible.
How many in the room have been touched by cancer, by a loved one and so on? Yeah, about all of us. You know, today's statistics, 1 in every 2 men and 1 in every 3 women in our lifetimes will be touched by cancer. So it's still there. I think, but this blood test was, you simply go in and they draw vials of blood. You fill out a little application. You can even do it online. And it comes back and it just gives you a great peace of mind. And the nice thing about this trial, is this the Vanguard trial?
Mm-hmm.
Is that it is the false positives are very, very few. So we don't say somebody has to go through all this when they really don't. But we have also found a couple of cases that are true cancer and been able to treat it early and save a life early. So it's something to talk to your doctor about. Or can we provide information for the clinical trial?
Yep.
If we have captured your email or your contact and you're interested, I think we can do that for you.
There was a question over here. Yes.
Massey also saved my life 26 years ago. I am interested in having you talk some more about clinical trials. I'm in the PRECEDE study because of family history. That's to see if they can find early detection or a way to prevent prostate cancer not being found until it's too late.
All right, I'm going to give you a clinical trials 101. All right. So at Massey, we are fortunate enough to be able to offer different types of clinical trials. The trials that, I'm going to go right here, the trials that folks generally hear about are the treatment trials. That's mostly what folks hear about. You get diagnosed, and they say we have different types of treatment that we're going to offer you. You can determine whether or not you want to have it or not. And one of the things I like to tell folks is there's always this question about the placebo, okay? The way that clinical trials works with treatment, you're going to at least get the standard of care treatment. You're not going to get nothing. That's not how our stage 3 and larger trials work. So either you will get whatever the drug that we're trying to test, or at the very minimum, you'll get the standard of care. That's treatment trials. But the other side of trials are the non-treatment trials, which are just as important. And these trials focus on, I wonder if we can get survivors to exercise while they're on treatment. Can we lower their risk of heart disease later? Or I wonder if there are some studies that we can do around communication between patients and physicians to help increase patients' quality of life because their physicians are listening to them. So all of these are trials that, one, not only help with better treatment, but it helps with better care once you're in the health system. And then there are some trials that help with better quality of life as you go through survivorship. And fortunately at Massey, we're able to offer all of those type of trials. Any other questions? Oh, there we go.
Developed prostate cancer at 37. His father had died from it, and he had been diagnosed young at 70. I mean, 60. And they're talking more and more about that. And see, he wouldn't have fit into any of this.
Right. I'll repeat it. Absolutely, I'll repeat it. So the concern was about younger individuals getting cancer, okay? And she mentioned her son developed prostate cancer in his 30s, correct? His father had it at 60. But at 30, he was not going to be screened. That was not there. We see the same thing with breast cancer, unfortunately. 20-year-olds, 30-year-olds, they're not screening age yet. We see the same thing with colorectal cancer. This is a growing problem and concern. I would love to stand in front of you today and say we have pinpointed the reason why we see this. We have not. Yet at Massey, this is a point that we're trying to focus on. This again gets at what Becky was saying, why it's important for us to get those experts here that are studying maybe the environment, the type of food that we're eating, and how that interacts with your cells and everything that may contribute to why we're seeing cancers in younger individuals. We really don't know yet. A lot of signs are pointing to environmental factors and how it plays a role within the body and what's considered like the microbiome. But these are all things that we and other scientists across the world are trying to investigate, but we really do not know why we see it yet. And unfortunately, we don't have a lot of the evidence now because one would say, well, just lower the guidelines, make it 20. But then we get the concern with that is like, what is the rate of, like, again, going back to false positive and negative, how many of those folks might we see something in and might not be in? And so we don't really have the evidence, even though I was one of those ones that's like, let's all get screened. We're just not there. And so then it gets at it gets at what Becky was talking about, so your family history. And then it's like, what can be, like the woman back there asked, what can we do about like the genetics and the genetic testing? Is there something there available to look at? Yes. What are we on time? I'm sorry. I can run all day. Okay.
Thank you. Is there any evidence that the number of cases will increase over the next 10 years because of the growing population, particularly?
All right, so are there any data that the cases are going to grow in the next 10 years? So we know that cancer has always been considered a disease of aging, just like cardiovascular disease. We know that our population is aging and living longer. We know that, so because of that alone, we do expect the cases to go up. That's why we have been seeing this trend go up. In addition to that, the aging population, it's the modalities are how we are testing and how we're screening. Screening is getting so good. Even with like mammography, they're using AI now and they're able to detect tumors, like the tiniest sized tumors. So because of that, we do expect numbers and cases to go up. But the flip side of that is like we have these great treatments and I think there's a school of thought that one day cancer, if we can't eradicate it completely, it will become like another chronic condition where we're able to treat it. And then people can live their long lives after a diagnosis. But I think that is the way that we're trying to go.
I think Mary Ann's going to close us out, but it also gives us reason once again to say thank you. Can you imagine this beautiful, intelligent, so brilliant scientist we have on hand working at Massey Comprehensive Cancer Center to help all of us figure out the screening, what we should be doing, how to live better in our environment, how to survive it, how do we find it? And how do we treat it earlier, and how do we serve our community? So, Dr. Sutton, thank you. You were excellent. No reason to be nervous. And I just personally want to one more time say thank you for what you've done in advancing cancer care and research right here in our community for our people. Thank you, thank you, thank you. Mary Ann's going to close us out. Dr. Johnson, I'm sorry.
That's okay. I think we ought to thank them for coming. I think it was very informative. And I think the biggest thing is you know your body and your family history. So if there's something going on, make sure your children know it, your grandchildren know it, and everybody will be on high alert for surveillance. The earlier it's caught, the better the prognosis.